Okay, boss.
Yeah, good.
And you want to sound?
1800.
You want to give it another minute? Okay. All right, very good. Sorry to disappoint.
Right. Yeah. I think I just put them off the separated the yeah.
So, very good.
Yeah.
I think we should do that.
Atukia te urunga, atukia te moenga, ko marama heke te pō, te ko I te ko ia. He whakarahia, hira mai te hihira, wara mai te ara, he manu whakarongo, tupua koa te manu nei, a te tōre uta, ko whete mai angutu, ko tū ki taha maui, ko rongo ki taha matau, tuturu whakamawa ki a tina. Tina. O me ue, tai ki. A korori ki te atua runga rawa he mango rongo ki runga te matua te whenua he whakaro pai ki ngā tangata katoa. A tihai Māori tū, a tihai Māori ora. A tihai Māori ora. A papa tuanuku ki roto, ranginui ki runga. Tēnā kōrua, te whare e tū nei, e tū. Ki ngā mate kua haere tonu haere. Haere ki huaiki nui, huaiki ro, huaiki pāmāmā. Haere. Ki te hunga ora, tēnā koutou, ka mihi atu ki a koutou ngā iwi tuku whā, ngā tangata whenua o whakatū nei, tēnā koutou kei te mihi. Kei te mihi atu ki a koutou, ngā rangatira mākua tai mai ki tēnei, ki te tautoko tēnei kaupapa, te kaupapa mate wareware, tēnā koutou numa hara mai. Ki a koe te rangatira Don, tēnā koe, kei te mihi. Kei te mihi atu ki a koutou ngā hau e whakua taimai ki tēnei ki te tautoko tēnei kaupapa. Kei te mihi, nau mai hara mai. Ki tēnei kaupapa tino uaua, ki tēnei kaupapa maha te rongoa, maha te roimata, maha te tangi, no te mea e ua tēnā, e moke ana mātou, no reira, no te mea tuku pāpā e mate wareware ia, kare ia I te mohi o a hau, no reira, kei te mihi atu ki a koutou. Ko mutu tuku mahi ki roto I te reo Māori, te mutungo te kōrero me waiata. So, e hara I te mea, noa naine te aroha, no nā tūpuna I tuku iho. Kia ora, ko Alex Brown tōku ingoa, ko Tiatiawa tōku iwi, ko Puketapu tōku haku. Nō reira, tēnā koutou katoa. Welcome everyone. I said a few brief words in Māori. And those words included a karakia to start off this kōrero, which talks about the beginning of the world, the beginning of time, the creation of man, the creation of conflict and peace, and how we come together to be as one. I then gave thanks to Papa Tuanuku and Ranginui, and then I said hello to this fine whare and told it to keep standing. And then I said hello to and welcome to our guest speakers tonight, who have come from near and far to talk about this important topic. And for me, it's an important topic because my father has dementia, and it's been very upsetting to see his decline. And I welcomed you all here today to hear about some of the things that are going on in this very important topic, because apparently 50% of people over the age of 85 have some form of dementia. So, and I think it touches every family in New Zealand. So anyway, I'll let the speakers talk about it, and I'll leave you to it. Thanks very much.
Kia ora, tēnā koutou katoa, ko Don Wilson, ahau. Well, thank you, Alex, and greetings and welcome everyone to our 4th Community Health Lecture here in the Suter, or else joining us by Zoom via telehealth. My name is Don Wilson, Regional Associate Dean for the University of Otago here in Nelson, and I'm delighted to chair this event. Just to give you some background to these Community Health Lectures, the idea was conceived by Lexi O'Shea, there's Lexi there, who until last Friday was the CEO of Nelson Marlborough Health. She's now got a new title. Lexi, Alex, and myself put forward a grant to the CARE Foundation for 6 lectures over 2 years. We're very grateful to the CARE Foundation for their funding. The principal aim of these lectures is to engage with our local community, specifically to educate, inform, challenge the Nelson Marlborough public on current health matters, including an equity focus. As Alex mentioned, this lecture is on dementia, a very important topic, and it was also the choice of the people who attended the first 3 lectures. We asked them, what would you like to hear next? And the top of the poll was undoubtedly dementia. So as Alex said, we've got 4 excellent speakers. The first, and he's our out of town speaker, comes from Christchurch, is Matthew Croucher. Matthew is a psychiatrist of old age, senior clinical lecturer with the University of Otago in Christchurch. He's a dementia expert with national leadership and academic roles, as well as being a specialist for people affected by dementia of any age. He's going to shed light on what dementia is, how common it is, and the main management and treatment options. So thank you, Matthew, very much for joining us tonight, Dr. Matthew Croucher. Thank you.
Kia ora, thank you very much for that introduction, and Namiki for the introduction as well, and the welcoming to us all, Alex, and an acknowledgement of the mana whenua that I from here is also to Lexi, hi, just acknowledging you as director of Te Whatu Ora Nelson Marlborough now as it stands. So folks, I'm a Nelson boy actually. I wasn't born here, but I grew up here, so this is home. So it's lovely to be back, and it was lovely to spend the weekend with my father who lives here. So Croucher is indeed a Nelson and Richmond name, as anyone who's driven to Richmond Mall down Croucher Street will know. All right, so let's begin this kōrero about mate wareware, about dementia. And all I want to do is start the ball rolling by making sure that we all know what we're actually talking about, because dementia is one of those things where we think, oh, I sort of know about that. But if you had to define for your neighbor, what's the difference between dementia and Alzheimer's disease? I think most of us would start drawing a blank. So I just want to start off by some definitions, but also to acknowledge the different organizations that I work with. And Canterbury DHB is also renamed. So Te Whatu Ora Waitaha is now the Canterbury branch of a health system. So what is dementia? Well, if we were to choose a definition that you could find in a textbook, it would be long and it would be complicated, all right? So dementia is indeed the syndrome of acquired significant impairment due to cognitive decline across multiple domains caused by a neurodegenerative disease. What on earth can we make of that? The first thing to say is that you weren't born with it, so you get it. I didn't used to have it, but I have it now. All right, so it's something that happens at some point in our lives, and if we get it, and later in life, usually. In fact, the biggest risk factor, which isn't to say cause, but the biggest risk factor is advancing age. So the older we get, the more at risk of maybe developing a dementia problem we are. So it's acquired. The next thing is it's not the same as normal age-related changes in our brain. It causes significant impairment. And significant is defined in terms of, does it stop you from getting about your normal life without needing a bit of help? The next part is that it is to do with our brain power, our memory and our brain power, our thinking power. So that's cognitive, to do with thinking. That's not all it is, but it is that, as well as some other things. It's a brain issue. And in not just one part of what our brain does, so not just memory, or not just language, or not just the ability to move my arms and legs reliably, but more than one part of what my brain does. And it's caused by a disease where brain cells get unwell and unfortunately stop working properly and eventually die. So it is a brain disease. So in shorthand, it's chronic brain failure. It doesn't mean that your brain has completely failed. We call that death or unconsciousness. But chronic brain failure just means my brain is over the long term, years, not days, starting to fail to do the jobs it used to be able to do. That's the shorthand. And you may know some phrases like this for other parts of the body. Have you come across someone that had heart failure? Have you come across someone that had kidney failure? Have you come across someone who had joint failure? Actually, no, you haven't. We call that by a code word, don't we? That's called arthritis. So you see how we have code words in medicine for some of these things. In chronic brain failure, we have a code word, and we use the word dementia for that. All right? So the next thing to learn about this diagnosis is that it is an umbrella term, rather like arthritis is an umbrella term. It just says, arthritis, that my joints are starting to fail to do their normal job, which is to move easily and smoothly and hold me up. But it doesn't tell you what disease has caused my joints to start to fail. Because there are lots of types of arthritis, aren't there? Have you heard of osteoarthritis? Have you heard of rheumatoid arthritis? And for extra bonus points, have you heard of psoriatic arthritis or other autoimmune arthritis? So dementia is the same. It's an umbrella term. It says my brain is beginning to have some trouble doing its jobs, but it doesn't tell you what disease has caused that. And in New Zealand, the commonest causes of this dementia problem are these diseases. So Alzheimer's disease is the commonest cause, but there are others. Vascular diseases, cerebrovascular problems, frontotemporal dementias, alcohol-related dementias, this thing called Lewy body dementia, and then dementias related to some other movement disorders like Parkinson's disease can cause a dementia for some people. So now do you see the difference between Alzheimer's and dementia? Alzheimer's is a disease which is a common cause of this thing called dementia that we recognize when we see it in our next door neighbor, but it's not the whole of the umbrella. It's just one part of it. Does that make sense? All right, good. So that's what we're talking about. Now, how much of it is there about? I just thought you'd like to see this picture, by the way, to remind ourselves that it's not normal. one of these brains, do you remember Sesame Street? One of these brains is not like the other. One of these brains is not quite the same, all right? It's not normal. Something's gone wrong. There's a disease here. All right, so this is talking about the New Zealand population. And if we were thinking about how big is the New Zealand population now, it's just over 500 times 1,000. 5,000, sorry, times 1,000. So our scale on the left-hand side would go up to 5,000 thousands to have everybody in New Zealand in this picture. But I hope that you can see here that just a few years ago, if we counted all the people in New Zealand over 60, there were about 1.1 million. But if we jump ahead, and not that far ahead, to 2037, we will have jumped up to nearly 1.6 million. That's another nearly 500,000 people over 60. That's quite a big jump, considering that a couple of years ago, there were about 1.1. So that's big. That's like nearly a 50% increase in just a few years. And if we look at the oldest a couple of years ago, nearly 100,000 in New Zealand. But in that short time, it's going to more than double to absolutely 200,000. Now, the reason why this is important is because this explains one of the main reasons why there seems to be more dementia around at the moment. It's not because the world is a more dangerous place full of toxins that are causing dementia. It is because the biggest risk factor for dementia is aging. And for the very first time that we're aware of in the history of the world, in a country like New Zealand, there are as many older people as there are younger people. And that has never happened before, as far as we know, in the history of the world. The aging population. And it is not because our older people are gasping their way through their old age, connected to dreadful machines and being looked after in aged residential care. No, thank you. They're getting on with their lives at home mostly. And there are a few older people, if I can generously say that for some of the audience tonight. So most older people are doing quite well, thank you very much, but they are older than they used to be, and there are many more of them, and that is a blessing for our society, not a curse. But that is the reason why there's much more dementia around now. And why is that? So in a country like New Zealand, there are two reasons for that. Reason number one is the baby boomers have reached old age. Nearly all of them are now over 65, and the earliest of them are approaching 80. But also that we're all living longer anyway. Those are the two reasons. Okay? And that means that the number of people in New Zealand living with dementia, which was round about 50,000 a couple of years ago, will be round about 110,000 in just a few years' time. And that is more than a doubling in a short space of time. That's why we've got to get our noggins in order. And dementia is not just a Me Too diagnosis. It's not just here's another thing that we all have to be careful and sort ourselves out about. Dementia drives a large proportion of the health demand that Te Whatu Ora needs to manage. But more than half of our citizens living with dementia don't even have a diagnosis yet. So you can't even count them properly. So we've got a lot of work to do. So there are the numbers in more detail. Now, the final thing I want to do is tell you a little bit about what is the science of dementia management at the moment. What do we do? I don't think this slide is terribly interesting, but it's just to tell you that New Zealand is right along with other countries that are reasonably similar to us in terms of the prevalence as people get older. It's a different way of explaining that age is the most important risk factor. Now, the management of dementia has 3 legs. There are 3 important parts to it, and they are standard medical care, good, solid medical care. And that doesn't mean just from doctors, that's from the whole of the healthcare team. Person-centered care, which means thinking of this person living with dementia and seeing that the most important thing about them is not that they have dementia, but that they are a person. And therefore, that any of the things that happen to them, say, for example, for someone with a good going dementia, that there's some behavior that we find kind of reasonably challenging. The most important thing at that moment is not the behavior and whether it's a symptom or not. That would be a medical way of thinking about it. It's saying, well, that's what people will do. People behave like this. Why is this person behaving like this? What's going on? How can we work it out? And probably they're behaving like that for the same reason that any of us might behave like that. I'll give you an example. Someone with dementia might occasionally shout quite loudly at you and be really angry. And the person-centered way of thinking about that is thinking, well, why do I get really angry and shout at people? Well, it's when they piss me off. That's one kind of time. It's not really a medical way of thinking about it, is it? What are we doing that might be provoking this anger, rather than saying, well, clearly this person needs a drug? Do you see how it's a radically different way of thinking about the same phenomena? It's very important. And the 3rd leg on the chair is disability support. So this is a way of saying, you need some extra help. What extra help can we give you so that you can manage really well in your life? I'll give you some examples of what fits in these boxes. So standard medical care is talking about, well, I'm very sorry to tell you that you have a dementia illness. How can we boost the health of your brain? If I don't have a cure for, say, Lewy body dementia or Alzheimer's dementia, what do I have? Well, I might be able to boost the health of your brain. Would that be a good thing? The answer is yes, it would. I might not be able to cure it, but can I slow it down? That's modifying the progression. I might not be able to cure it, but you're having a bumpy ride with awful symptoms right now. Can I help you with your symptoms? Yes, I can. Are there bad things that you're at risk of? Risk of falls, risk of malnutrition, risk of getting pneumonia? Can I try and prevent those things? And if you get them, help you to recover more quickly? Can I prevent some of the complications that come from this type of dementia that you have? And while I'm with you, since our whole health system is built upon people saying, oh, I'm feeling a bit sick, I must make an appointment with my GP to get that seen, but dementia sort of stops you from doing that very well. Maybe I need to start offering you healthcare and ring you up and say, come and see me. I'd like to check how you're getting on. So this is the standard medical treatment for dementia, which is why when I occasionally hear from doctors, I don't want to diagnose it because it just upsets people and there's nothing I can do, I think, well, that's an incredible failure of imagination. And by the way, do you ever see people with congestive pulmonary disease? Do you ever see people with arthritis? Do you ever see people with Parkinson's? Oh, you do, right. You can't cure those things either. Well, okay. Person-centered care is about education. It's about planning ahead. It's about helping people to increase their social capital. That's the connectedness that we have with other people and the value that other people place on our relationships with them, because dementia attacks this. So we have to build it up. Meaningful activity. So this is things that this person would like to do. We've got to help them to continue to do that. And I have to say that in Te Ao Māori, the whole way of seeing a person as still vital and intrinsic to whānau and to marae processes and supporting them to continue to be there, because without them we can't do this thing. But yes, I may have to help you with karakia at times if you forget the words. This maintains the personhood of that individual in a way that in Pākehā culture we've got a bit of a way to go. Disability support we're pretty good at in this country. There's holes, and there's things that we can do better, but the structures are there. You want to get, if you have to have dementia, Nelson Marlborough is not a bad place to get it compared to great portions of this planet. Now, I want to finish just by saying out of this list, there are some things that jump out in red that a kaupapa Māori way of thinking about mate wareware will help us all. Now, the government is about to release its national dementia strategy in a more formal way. And that privileges, like so much of the current health reforms, focusing on the groups whose needs are most egregiously not being met, and that includes tangata whenua. Now, there's a total fairness argument for that. But besides the fairness, I want to point out to you that if we can get our dementia services, our mate wareware services right for whānau, we will be able to take those positive things for everyone and the benefit of all in Aotearoa New Zealand. And that's a big part of my work. So I wanted to let you know that I'm in that fight, and I'll keep on until we win. Ladies and gentlemen, that's all I wanted to bring to you to start off with, and I'm very happy to hand over to my next colleague. Thank you.
Thank you so much, Matthew. I'm a gynecologist, so I found that really fascinating. So thank you so much. We're actually going to have questions at the very end. So I'm going to introduce the next speaker, Nikki Baxter, who is a geriatrician working at Nelson Hospital and the Nelson Tasman community. She supports general practitioners, community providers with the care of people living with dementia. Nikki is going to talk about the process of diagnosis, the local referral options. So thank you very much, Nikki.
Excellent. Tēnā koutou, good evening everybody. Thank you for that introduction and welcome to our evening tonight. First of all, I wanted to start by talking about why it's important to get a diagnosis of dementia or mate wareware and what the local supports and services are in our community in Nelson, Tasman. I'd also just like to disclose that I'm employed by previously Nelson Marlborough Health, which is now Health New Zealand. So first of all, why is it important to get a diagnosis? And it comes down to the fact that without a proper assessment, it's hard to know whether what you or your loved one is experiencing is dementia. And so having that proper assessment looks to see if there's any other medical conditions that might be going on, which may present similarly to a dementia, which the course of treatment would be quite different for. And then if it is a dementia, it's important to get that diagnosis early. And that's for a number of reasons. One is that if you know the diagnosis early, it provides a sense of relief or reassurance that you know what's going on, that you can prepare for the future, that you can access medications or strategies to improve your brain health and prevent or slow any further decline, and also to be able to access support services that are available. So there is benefit in going and getting assessed by your general practitioner. What would your general practitioner be doing? So first of all, they'd be taking a history. They'd be wanting to find out how long these changes in brain function have been going on for, and what specific things have you been noticing or your loved one been noticing, whether that's changes in memory, attention, language, spatial awareness, reasoning or judgment, and what problems this is having on your life, what impacts is this having on your life. They may be interested in any medical conditions that run in your family and what medications you're currently taking, including over-the-counter medications at the pharmacist, because some medications, commonly prescribed medications, can cause confusion, and so it's important that they're reviewed. They will also want to speak to whānau or a close friend to find out what changes they've noticed, because what we know is that people from outside see things differently to what we will see. And so getting the story both from the person with cognitive change, but also from an outsider is really important to paint that picture. They would be doing a physical examination to look for other medical conditions and a neurological examination, but also to assess people's mental well-being, because as I'll talk about, depression can be a mask for dementia. They will be doing a cognitive assessment, either themselves or their practice nurse, which will be a screening test looking at different areas of your cognition to try and assess what areas have been affected and what severity these changes might be. And they'd also be arranging blood tests and possibly brain imaging to look for other causes or try and get more of an understanding, if there is a dementia process, what type of dementia this might be. These are some common medical conditions which can present like a dementia. On the top left-hand corner, that signifies depression. And depression, or sometimes we know it as pseudo-dementia, can be a masquerader of dementia because it causes people to slow down with their brain function, and they think slower and have less motivation to get out and do things. And depression's very treatable, and so it's important that that's picked up. Alcohol can cause problems with brain function and slowing of brain function, particularly as we get older, we're more susceptible to the effects of alcohol, and stopping alcoholic drinks can cause the brain function to improve. So it's important to consider alcohol as a cause of cognitive changes. A head injury could cause bleeding, which would require separate treatment. Medications we've talked about, but other conditions like thyroid abnormalities, calcium abnormalities, B12 vitamin or folate levels, and also diabetes, if it's not treated or not properly treated, can cause people to be confused and present a bit like a dementia. So the GP with all this information would help to arrive at a diagnosis, and they may actually refer to a geriatrician, a neurologist, or a psychiatrist to get further opinion. And then there may be other people, physicians or endocrinologists, neurosurgeons, who they end up contacting if a different process has been going on to cause problems with cognition. There's lots of other health professionals out there who the GP may refer someone with dementia to, and that's to try and help boost their function at home and to help with any symptoms that they may have. Speech therapists, physiotherapists, occupational therapists, dietitians, social workers, Te Piki Oranga, who is a kaupapa Māori provider here in Nelson, Tasman, who help to engage Māori whānau with the health services and make sure they're getting equitable care. And age concern, who I'll talk about soon. The GP will talk to the person about arranging an advanced care plan, which is a setup to a document saying what someone would want if their health was to get worse and what their priorities are. And that can change as time goes on, as people's priorities change. And that's separate to setting up an enduring power of attorney, which is through a lawyer. And that's appointing somebody to make decisions on your behalf if you are unable to make decisions because you no longer have the capacity to do so. And having somebody that you trust who has that legal authority is really important for all people, whether they have problems with their cognition or not. Alzheimer's Nelson Tasman, we're going to hear from Heather later about that organisation. And Age Concern is another organisation which your GP can refer people to. They have lots of social programs, educational sessions, and support and advocacy for people, including people who are vulnerable to abuse. And the Needs Assessment Service is based out in Richmond. Now, some of you may be familiar with groups like Access and Nurse Maud. So the Needs Assessment Service, they come out to your home and do an assessment to work out what supports need to be in place to help you live an independent life. They have access to respite, which is to provide carers with relief and a bit of R&R to help prevent them from getting tired or fatigued. And that can be at residential care facilities around Nelson. They also have funding that a carer is able to pay somebody else, a family member or someone in the community, to come and sit with somebody who has dementia, to give them a time that they can go out and get things done around the community or take time for themselves. They're also able to provide access to community groups, the Harakiki Club, Total Club, and Stoke Seniors, and they're groups which are day activity programs for people both with dementia or people who don't have dementia, who are socially isolated or lonely and want to have more social engagement. And those groups often have services that can pick people up from home and also be a way to be able to support the carer to continue to care for somebody with dementia. And that's all I wanted to speak with you all about tonight. We'll be hearing more for questions later on. Thank you.
Well, thank you so much, Nikki, and thank you too for sticking to time, both speakers. So that's marvelous. Thank you. The next speaker is Chris Gall, who is a clinical nurse specialist in gerontology in Nelson Hospital. She works closely with Nikki, and Chris is going to talk tonight about dementia management in Nelson Hospital. So thank you, Chris.
Hello. So I wanted to just speak for a few minutes about some of the, oh, sorry. Oh, that's not my one. Sorry. Do you want Heather to come up next? This is Heather's. Where did you go? Shall I just wing it? Thanks, Brendan. Oh, gee. Yours isn't there. Is it there? It was there. It was there. Yeah. Share window as closed, okay.
Your slides?
I've just got 3 slides.
Hmm?
3 slides.
Those
None of those, no. I can just, I'm only talking for a wee while, I can just talk.
Have I missed putting them in the main presentation? I didn't realize that.
It's okay, I can wing it.
So this is the next presentation.
This is Heather's, yeah.
Okay. I do apologise.
That's okay.
It's definitely my fault for not putting them in where they were supposed to be. I must have put them over the top or something. It's not those ones, no. It's not, okay.
No worries.
They're not there. Let's do it. Because I do have them here. Yep.
I'd rather dance. I can just talk if you like.
I'll just do it.
Okay, so as you know, I'm a nurse and I work at Nelson Hospital as a specialist nurse working with older people. Oh, geez. Can you hear? Oh, you can hear me now. Okay, so what's the echoing? So, you know, I'm a nurse working at Nelson Hospital, and I work predominantly with older people around the hospital, with a special interest with those with dementia. And I wanted to just speak for a few minutes about some of the strategies and tools that we've put in place to help the person with dementia when they come into hospital, to help relieve some anxieties related to being in an unfamiliar environment, and to promote person-centered care. Going to wing it, okay. So one of the first tools we use is if you imagine a picture of a sunflower, and the middle part of the sunflower is where we write the person's name, and each petal of the sunflower has a different interest or the person's job that they worked as, pets, family members, special places to that person. And the role of the sunflower chart is that family members and the person with dementia can help fill that chart in. And what it does for us healthcare professionals is help get to know the person as an individual. And that's really useful to help with conversation starters. Thank you. To help distract or help calm somebody down if they're becoming restless. And as part of asking the family members to fill this in, we might also ask for them to bring photos in. And this is really trying to get to know the person as an individual and not the person as a person with dementia or for whatever reason they've come into hospital for. Some of the other tools we have, really obvious, clock. We've put clocks in all of the rooms so that all of the bed spaces can now see a clock as a way to orientate to time, which seems really obvious and really simple, but it makes a big impact to the person with dementia. We've also made signs for the walls which has the days of the week on, and that's written in English and Kōrero. The fiddle mitts, these woolly things on the side here, are handmade kind of knitted items that help people with dementia that are really fiddly with their hands, and it helps distract them from pulling out IV lines or other tubes, so they're quite useful distraction. And the other thing that we've introduced is the use of speakers to play music. So for some people with dementia, they may need close observation, which requires one staff member to be in the room with that person. They may be in the room with other people, which usually can aggravate the situation, but we're trying to make the best of the situation that we have. And we found that by playing music can really create a really calming and peaceful environment. And so far, we haven't had any music taste challenges. And then we've got our animal friends. So this dog we hear weighs about 4 kilos, and we find that having that on the bed with the person with dementia provides quite a lot of comfort. Again, it's a bit of a conversation starter. The person with dementia may have had a dog in their prior life. And the dog, again, can be used as a distraction. It sometimes gets given names, nice names, and also can be used to blame for all kinds of other mischief that they might get into. And the cats here can be activated so that they're breathing and their stomachs go in and out like they're breathing, which is quite soothing to watch. And again, can bring quite a lot of comfort to the person with dementia. And that was all you've waited for me. Thank you.
Well done, Chris. I think it's every lecturer's nightmare to come up and then they can't find your slides. And then for you, it was a double whammy. Not only did they find the slides, but they didn't work. So anyway, Chris, so well done for that. The last speaker tonight, hopefully, is Heather Lechner, who's the manager and dementia educator of Alzheimer's Nelson, Tasman. So Heather is going to talk about the support and services that this organization provides. Okay, Brendan?
No, just give me a minute or so.
Okay, very good. Okay, Heather, do you want to come up? So as you're all set to go, shouldn't be too long.
Thank you.
Round of applause.
Just check that person. Okay, I just need to turn your microphone up.
Good evening, everybody. It's lovely to see so many people here. It shows that there's a real interest in learning and getting knowledge around dementia. So tonight, I'm going to talk about the services and supports that Alzheimer's Nelson Tasman provides in our region. So Alzheimer's Nelson Tasman, we're a not-for-profit organisation we provide support for people with all types of dementia, not just Alzheimer's, which some people find a bit confusing because we're called the Alzheimer's Society, but it's all types of dementia. And you do not have to have a diagnosis to access our supports, which is really important. Our referrals come from a lot of different places. We get referrals from GPs, we get referrals from the hospital, from ATNR, the geriatricians, and we get support referrals from community services as well, and also social services, and we actually get a lot of self-referrals and family referrals. So we have, when a referral comes into our service, it's received and it's allocated to one of our 2 dementia advisors. So we have one dementia advisor that services from Rye Valley through to Stoke, and our other dementia advisor services from the Tasman area. So they do Richmond, Motueka, Golden Bay, as far as Murchison and up to the Lakes District. And what happens is we make contact with the families, whānau, or the person that's living with dementia, Mati Wareware, and we see what it is that they want and how we can support them or what they need. And it's usually one or all of these 3 things. So first of all, it may be education around the disease, education about understanding behaviours that they're seeing in the person that they're supporting. It may be about learning new techniques on communication. So whatever that they're experiencing and what they're going through, we see if we can provide the education, and if we can't, then we'll refer on. We're mindful that often what you need now changes as the dementia progresses. So we actually try and explain that to the people that, you know, we're giving you a snippet of what you need now, but there will be more to come. It may be around information. So it's information about support service that are out there in the community. It may be around planning for the future, talking about enduring powers of attorney, giving them information about advanced care plans, where they can go to get those done, or actually supporting them to do those. It may be around crisis planning, which is often, that doesn't actually often happen, and it's often that we get involved when a crisis does happen. So if we can get in there before that happens and help them plan for that, it makes that journey a little bit easier. We can talk to them about appropriate day programs, about getting a needs assessment, accessing and how to access carer support and respite, and providing them sometimes with templates about how they can talk and have conversations with GPs, especially if they don't have a diagnosis. Support. So support is about walking alongside the person living with dementia, their care partners and whānau, in a way that they want and respect, and that actually everybody's quite different in what they need and want. So we have to respect that. And we discuss with them what their support might look like for them, because it is different for everybody. And it may be that we have the initial contact with them and that all they want is information, education. They don't need the support at the moment, but we say to them, well, okay, what say we contact you in 3 months' time? Again, they may not want to see us again, but 6 months' time down the track, they might say, hey, listen, we need some support. We need to see you. Can we organise that? So our supports that ranges from phone calls to emails to texts now. You know, it may be visiting us in the office or visiting them at home. Whatever that support looks like is what they get. So for us, it's about working with them in a way that works. So it's all about them, not without them. Another service that we provide is our carer partner support groups. So in our care partner support groups, it's a place where people can connect, they can share their experiences with each other, they can talk about things that have worked for them or things that may not have worked for them, so that other people can trial and see what will work for them. It's a safe place, and we often will, you know, have people that share their tears and laughter or their frustrations and joys. You know, it's a safe place where they can say what they like. You know, we have people that come in and they might say, oh my goodness, I really just don't like him today. And everyone knows what they mean. You know, it's not a judgment. Our support groups, they are facilitated by a dementia advisor, and we have 5 support groups that we run throughout the region. And we have one online support group now, which runs in the evening. And that is for people that can't leave their person at home on their own, or for people that are working and can't get to the day support groups. We have our social support service. So this is, these are peer groups. It's a service about keeping people connected, reducing isolation, and it can also be about supporting people to stay engaged in activities in the community that they may have lost confidence to do and have withdrawn. So it provides an opportunity for people that are living with dementia to connect with other people that are living with dementia. And the aim of these groups are often, it's about empowering people to maintain and enhance their skills and abilities to cope with the challenges that they may face and explore and managing now and into the future. We have 5 social support groups that are running at the moment, and we also do one-on-one support. So that's about connecting people together with similar interests, so that that they can stay then connected with somebody else and go to activities that they've once been involved in the community. The groups for our people living with dementia are actually run by the people living with dementia, so they get to say what they do at the groups and how it's run. The one thing that we have to do is we have to make sure that it's fun and that they want to keep coming. Yeah. We also run what we call our Els cafes. So they are cafes that are held in cafes in the community. As a person with dementia progresses, it can sometimes be difficult to go out and have coffee together because the communication no longer happens. And so what happens is that the person with dementia and their partner stops doing that. Whereas when they come to a cafe like this, it's supported, we have volunteers there. And it means that they can talk to other people, and the person with dementia can still have conversations with people. It gives the person with dementia connection, and it also can give the care partner a wee bit of respite. We have 3 of these cafes running. We have one in Motueka at Toad Hall, we have one at the Boathouse at Tahuna, and one at the Dress Up Box in Richmond. We also work with the Nelson and the Richmond libraries and run book and dementia friendly groups, which keeps people engaged again in community venues. Education. So understanding dementia can be a difference between a positive journey and conflict, and education is really, really important. So we have education for our care partners. This can be one-on-one education. It can also be, we run caring with confidence workshops. So where we run a number of different topics at our workshops for care partners. We have education specifically for people living with dementia. So that can again be one-on-one, or it can be, we run some take charge workshops where again we work through the process of talking and discussing around things that can change for a person living with dementia. We provide community education. So the community education, these sessions can be tailored to specific needs of the community that we're talking about. So we can just have conversations around, we have a Dementia Friends program, or we talk about dementia friendly communities. We do brain health education, awareness of dementia, and also provide education about our services. And we provide education to health professionals, again, that can be around whatever is tailored and what are the needs. All our sessions are delivered by highly experienced facilitators who specialise in the delivery of educations and support around people with dementia. So some of our other services and resources we have a lot of resources at our office. We work in partnership with Search and Rescue with the Safer Walking program, where we have the Wonder Track pendants and also the memory loss bracelets, which we can help with our people living with dementia. And we also can provide assessments to access the RideWise card, the total mobility scheme through the councils. Yeah, and so there's just some of our different resources that we have. And I'm going to leave you with this. And thank you very much. Oh, you don't want that, you want me.
Thank you very much, Heather. Now I'd like to ask the four speakers to come up. We'll have some questions. Well, thank you, everyone. I'll try and be as equitable as possible with rotating questions from the floor here with the telehealth. Questions, I'll maybe just start while you're thinking. Nikki, you mentioned alcohol. How much alcohol would be appropriate for an older person to drink?
I think we can all appreciate it depends on the individual. And there is no safe amount and there's no wrong amount. I'm not here to tell everyone that they have to stop drinking altogether. And it really depends, I guess, in the context of what's going on. Is that working?
Yeah, sure.
So if somebody has problems with their brain function and they want to try and find something that they can do which will improve their brain function, then stopping alcohol is a really good option. And if you want to have the odd glass now and then, absolutely. And there's lots of alcohol-free versions out there, I know quite well now, or the different options there are. So that's what my answer would probably be.
Okay, I'm just, thank you. Excellent. We've got a question from Patrick Stowe. What can you do to reduce your risk of dementia? I don't know whether it might be easier for Nikki, your excuse, you can sit down, but if anyone else wants to, they can come up here because we're going to use the roving mics. Matthew, thank you.
So we're all pretty interested in reducing our risk, right? Me too. So there are a panel of different things, but I'll tell you the top two. So the top two are exercise and diet. So the trick with exercise, it is the most evidence-based thing that we can introduce into our lives to lower our risk later in our lives of developing a dementia. And there are a couple of important things about it. The first thing is it is never too late. So the beneficial effects of exercise, which aren't just for our brain, they're for the whole of our bodies, but the beneficial effects for brain, never too late. So that's the first thing. The second thing to say about exercise is it does not mean getting out a gym membership, with apologies to any people in the audience who own gymnasiums, although that's not a bad thing. But the exercise that human beings are designed for is walking. How much do you need to do? 4 times a week for half an hour. That just makes you a bit hot, you know, not staggering back in the door, but just you're warm. That's enough. Now, some of us can't walk, right? So this is a problem. They got their hips or knees or some other reason, but just something that will make you warm. But the short answer to how much exercise should I do is a little bit more. Diet, there's no end to how good we can take our diets. Rules of thumb here: if it's good for your heart, it's good for your brain. If it's good for diabetes, it's good for your brain. If it's good for cancer prevention, it's good for your brain. Actually, all these diets, if you look them up, they're pretty much the same. And in New Zealand, what that means is less meat, with apologies to the pork, beef and lamb marketing boards. It means less meat. We eat far too much meat. You don't need even half of what the average New Zealander eats in terms of meat. You don't actually need any, so less. But what you do with your plate then is expand all the things that are colourful. And those of us that grew up in households where you took those colourful things and put them in a pot with water and boiled the colour out of them and then tipped that down the sink and ate what was left, that's not how you do it. All right, so exercise and diet are the top 2 things that you can do. There is a much longer list than those, but those are the top 2 things.
Right, thank you, Matthew. Other questions from the floor? Yep. Thank you, Claire.
Kia ora, ko Neil toku inoa. Thank you very much for excellent presentations, and for all 4, I really enjoyed it. So thank you, it's very informative. My question is, where are we at with equity and dementia?
One of my jobs is to try and sort this out a little bit on a national level. So do you mind if I... not far. So it's a short answer. Long answer, well, equity in what way? So there is in the services for people living with dementia matawareware, we have the same problems that crop up across the entire health system with respect to tangata whenua. So Health New Zealand, as it is now called, has not met its treaty responsibilities ever. Okay, so that's the first thing to say, so that if you look at rates of anything, they're egregiously bad. So that's the first thing to say, but it's actually not just about tangata whenua in this country, with the protections from the treaty that were ignored by government and at times totally reversed. So it's not just that, but we also need to think about other cultural groups in New Zealand. And so we don't do well with Pacifica, who are our nearest neighbours. Auckland, the biggest Pacific city in the world, very poor. So that's the second group, but then we can also think about all immigrant peoples in this country of immigrants. But then there's other equity problems. So we have a real rural versus urban problem in New Zealand. Okay, so it's all very well if you live in Nelson, a block from the hospital and 5 minutes from Alzheimer's Nelson, but it's a bit harder if you live in Tapawera. And not impossible, but harder. All right, so that's our next problem. Then we have other equity problems between the rich and the poor. We have other equity problems between the deaf and the hearing. We have other equity problems between people who develop their dementia in their 80s from Alzheimer's disease and people that develop it when they're 45 from Huntington's. So we've got real problems there. So there are a number of equity issues. What the government has asked the system to focus on over the next 5 years are Māori, Pacifica, rural, and young onset. Okay, those are the 4 biggest equity challenges which government has said you go for those. And if you fix it for those 4, you'll fix it for us all. And there's some sense to that.
Thank you. Any other questions from the floor?
Tēnā koto katoa, ko Marie toko ingoa, Health Consumer Council. What do you think the ethnicities or top 3 or even top 2 ethnicities would be with the highest dementia or cases of dementia? Yeah, and in terms of providing education or helping them prevent that, what can we do? Like, will it be the Asian population or maybe some of the refugees who are actually coming here with PTSD or trauma? So what would be the ethnicities around?
Yeah, got to ask some questions. So look, the knowledge of my partners, I can answer that in as far as it's known, okay? Because we don't know the true rates of dementia for any population in this country because the studies have never been funded. But what we can say is we know what the risk factors are. So if you count up in all these different ethnicities in this country, who has the risk factors, then you can get an idea of where the problems are. So unfortunately on that front, Māori and Pacifica leading the way with risk factors, but most of these are reversible or preventable. And they're things like access to good cardiovascular care in midlife and access to good education in early life and access to good hearing management when you lose your hearing or your hearing is impaired. They're things that are entirely within our grasp. So that's the answer to that question.
Thank you. Yeah, question.
I just had a question about who funds the Alzheimer's Society in New Zealand. How much funding do you get from government?
Heather, do you want to come up for that?
So locally here in Nelson, we get 48% of our funding comes from what was our DHB. The rest we have to go out and find. And I can't talk for other, because it's different all around New Zealand. Yeah.
Okay, thank you. I've actually got quite a general question, a very large question on the Zoom. What are each of the panel of stunning speakers? Okay. What are each of the panel of stunning speakers hoping from the health reforms, which you've partly answered, specifically regarding dementia, which you have already answered? Matthew, others like to, of the panel, make comment of things that you would like with the health reforms?
What I would like to see is the distribution of funding that goes to our organisation to be prioritised more to older people, particularly in regions like Nelson Tasman, who have such a high proportion of elderly. And that number is only increasing. We're second to Tauranga in terms of regions in New Zealand for our elderly population. And there is, of course, the health dollar is being competed for by multiple groups, multiple specialties. And unfortunately, it feels that older people are often at the bottom of the pecking order sometimes when it comes to distribution of that funding. And so my hope is that with Health New Zealand, the distribution of that will be more equitable, and hopefully that will mean that there is more funding for older people, and that will in turn result in more funding for dementia care.
Thank you, Keith. Heather?
And I would be the same, funding. It's about getting more funding for our services so that we can deliver services in the rural areas and in other places. And, you know, there was a research done a couple of years ago, and what came out of that is that people were quite happy with the services that they were getting, but they needed more. And we can't give more with what we're getting, so funding.
And I'd like to say that when the health systems and any services are redeveloped or redesigned, that they are focusing on dementia-friendly initiatives. So if a bank can be a dementia-friendly organisation, why can't a health service? And you'll be surprised when you start looking at the requirements and definitions of what is dementia-friendly, how many of our health services don't actually meet those requirements. So.
Thank you. Chris, questions from the floor?
Nikki and I have spent a bit of time trying to learn how to communicate with each other. What I've heard tonight is very positive, and I congratulate you all. Thank you. Yeah, 30 years, like studying dementia, a lot of my bosses. What I hear from you before is a phenomenal range of care. 68 days of spending every night in hospital, like feeding and try and entertain. I haven't seen some of the places that were on. That is your desire. The only goal of my wife's was my big time. Sat in the truck now waiting and was rejected for the some made up story about he might have failed. Difference. The sickness is near, see him, medical unit, no problem, 18 hours, disgusting.
Okay. Okay. Okay, yeah. I'm sorry, do you have a question you want to?
I'm just hoping that what they are talking about tonight, sir, that they will.
Okay. Yeah. Yeah, thank you. Okay. Hey, thank you for that. We look forward to change. Can I just get a question from Joe Hobbs? Joe, I think is from Taihape. How can you persuade someone who doesn't want to be tested for dementia to be tested? First question. Second question, can testing be completed too early and therefore missed? Which of the panels would like to? Nikki, do you want to? Well, we're going to make sure we get another, yeah, sorry, just come up, Nikki.
So just remind me what the first question was. Oh, how can you persuade someone who doesn't want to be tested for dementia to be tested? A huge challenge. The first step is really for the person to make, the loved one to make an appointment with the general practitioner and describe their concerns. And you might recall in my talk how the history from the person is only one side of the coin. It's important to have that history from the loved one as well. And so even if you can't encourage your loved one to go along to the doctor, make an appointment without them and let their GP know about your concerns. And then they're really good at trying to work and engage that person in the process of establishing a diagnosis. And that might be done as routine care, routine checkups. So these things don't have to happen straight away, that the practice can work with the person who has the concern with their memory or cognition to try and get them to complete that assessment process. So that would be the first thing to do, is to make an appointment with the GP yourself. In terms of the other question,
Can testing be completed too early?
Can testing be completed too early? No. And the reason I say that is because when there are cognitive changes, it's really useful to see that change over time. So the first time a test is done, it's really just a snapshot of what's happening at that time. And it's really valuable to have another test 3 months, 6 months, a year down the line to see what's happening over time. And if there are changes there, then that can be more weight to a diagnosis of dementia, as opposed to somebody who might have a test and because of their situation, or anxiety, education level, they may not perform as strongly as what somebody might have done 10 years earlier, but actually that doesn't change over time. So it is really useful to have assessment early, and it can never be too early.
Okay, thank you, Nikki. Other questions from the floor? Yep. Got the mic.
Can TBI and or Parkinson's give you predisposition to dementia, Alzheimer's?
Yes. Think of it like this, right? So I've explained that dementia is it's when your brain stops being able to do its job as well enough to get by in the world, right? Caused by a disease. But what if something had already happened to that brain that meant that it had already been taken down a peg, but was still doing fine? Now, if you have one of the diseases in that brain that will gradually lead towards a dementia one day, you'll get there sooner, because the traumatic brain injury, that's what TBI means, bad knock to the head, has taken it down a peg. So you wouldn't say that the brain injury from that disease caused from that head injury caused the dementia, but it made my chances higher, or if I was going to get it anyway, brought it forwards. Now, Parkinson's disease is different, because Parkinson's disease is not a knock on your head once, is it? It is itself a brain disease that's gradually changing some parts of the brain. And so the answer there is a bit more complicated, and it comes down to what sort of cause of Parkinson's do you have and how is that affecting your brain, but that does raise our risk of dementia later on as Parkinson's travels forward. You need the healthiest brain that you can to withstand diseases of the brain. Make sense?
Thank you, Matthew. No other questions online, I don't think. Questions from the floor?
Tina Kota Katoa. I have a question for the whole 4 people. I have concerns, having been to hospital and hearing people speak on behalf of the person and not allowing them the time to find what they want to say. I have a great concern about that as a 90-year-old, and sometimes people speak on behalf, but I have been to the hospital and heard a lady being questioned and her husband or wife, whatever, answering on their behalf. And what I would have a plea for, and to ask you to answer that for me, is please give them time to answer for themselves. Because if we can't answer for ourselves and somebody's answering for us, we forget. Could I have a comment from the whole 4, please?
Chris, do you want to start?
Yes, I hear, and I'd like to say that doesn't happen, but it does. It does, yeah. And I don't really have any short, quick answer for that, other than sharing the education and the best ways to communicate with all people, regardless of whether they have dementia or not. Time is something that is precious to everybody, and it is something that is used often as an excuse as being in short supply. But I think at the bottom of the end thing is that we are all trying to deliver person-centred care, regardless of what that person is coming into hospital with. So we can do better. And with education and sharing of experiences, I feel that we can do better. But I do hear you, and it's something that we can improve upon.
And as when we talk to people, we talk about that sometimes a person with dementia, it can take them up to 90 seconds to comprehend what it is you've said. And 90 seconds actually can be a long time. So sometimes we just have to stop and wait. And that for a lot of people can be really hard because we want to fill in those gaps. So it is about just stopping and waiting. And I don't know how we get that across, except for education.
People with dementia in hospital or in other services, they arrange through all the services, all the specialties, and often with different groups or different health professionals who aren't that familiar with dementia care. And so from their point of view, they don't know to really give the person with dementia the opportunity or time. And that comes down to education on my behalf and my colleagues' behalf to really try and improve the dementia care that's delivered in Nelson Hospital and other services. So I'm really sorry that that's been your experience and that's what you've witnessed. There is, I think, an obligation to both the person who's asking the questions as well as to the support person in the room to give the person with dementia the opportunity to speak and to let their voice be heard. There is no excuse for it. They should be given that time.
Thank you, Nikki. Matthew, do you want to add anything further?
So I just wanted to acknowledge Ruby Eberhardt and her strong advocacy for those of us that are older and need special services of all kinds, but including people with dementia. Ruby, thank you for doing that. I think there's an onus on all of us to remember that when you go into hospital, I don't know if many of you have been into hospital or something, but I have, and you really feel anxious and on the back foot, right? It's not your strongest day when you're in hospital. So if you're the family person that's there, you'll be feeling like that a little bit too. And it is really okay to stop if the young doctor or the young OT or whoever is looking to you for answers instead of to the person with dementia. It's really okay to, when the person has asked you by mistake, to turn around and look at the person that you support with dementia and say, yeah, Mum, what do you think? And only then, if Mum's having trouble or sister's having trouble or brother's having trouble, then you might, do you mean, bro, this? Is that what you mean? But give the person the first chance. But you won't feel that that's okay. You feel nervous. Oh, we've got to perform for the busy doctors, blah, blah, blah. But actually, you are allowed to do that.
Can I just so one of the initiatives we implemented at the hospital fairly recently in line with Alzheimer's Awareness Month was the introduction of Dementia Friend. And so that's just a 20-minute online education session that anyone can do. We promoted it with all of our healthcare staff through 18R, the medical units particularly, to go online and do that. And a key part of that is being able to talk to somebody with dementia and how you might do that in any situation, regardless of whether it's a healthcare environment or not. So that's a really worthwhile resource.
Thank you. Any other questions? Yep.
How do you deal with somebody who has dementia and is in denial? They're in a care home, but they think that they shouldn't be there and constantly want to come home. Although I've spoken to the staff there and they're quite aware that the person should be in residential care, I still have repeated calls to take him home.
I've had him at the doctor's, who has confirmed that he definitely has dementia. So how do you deal with that?
This is something I come across a lot. And your situation is common, that there are people who have dementia who, as their dementia progresses, they don't have the insight into understanding that they have a dementia and what limitations or what impacts that has on their ability to do the things they want to do. And so there are many people in residential care who want to be at home but don't understand the reasons why they can't be at home. And unfortunately, us reiterating it to them isn't going to make them understand or to change that. And really, I think we need to be thinking about switching our focus to helping them to think about what they can do rather than what they can't do, and trying to engage with them about the skills they do have and trying to really optimize those things for them. And rather than trying to convince them of this diagnosis, actually not going into that topic of conversation and just living with them in their world and what they think is true, and not trying to judge or create conflict when things arise that aren't the case. And that's actually what gives people with dementia the joy and the enjoyment in life and the quality of life that we want them to have. And so it is common, and it's really tiring and frustrating and upsetting when you're getting phone calls all the time asking to take your loved one home. But it's part of the disease talking, and it's because they can't appreciate all the complexities involved that you can.
Thank you, Nikki. Any further questions? There's no more online as far as I could see.
Kia ora panel, thanks very much for a wonderful evening. Any suggestions on a similar note for carers that are getting verbally or strategies for verbal or physical abuse from their dementia patient that they're caring for at home?
That is a really difficult one. So it's sometimes it's about looking and finding the triggers, seeing, often what happens is as a person's dementia progresses, they lose the ability to communicate, and it will often become behavioural. And so finding out what it is, why it's happening, and if it's becoming, you're getting a lot of verbal abuse, maybe talking to Age Concern about around the abuse and neglect, talking to their advisor. But I would be suggesting looking for triggers, what is causing that, because often there is something that does trigger. And like Matthew was saying before about, when we're pissed off, we act in a certain way. And often a person with dementia will act that way as well when there is something that is triggering them. And you have to change your expectations and the way you have communicated with them in the past, because that doesn't always work now. Does anyone want to add anything else?
Okay. One last question, if there is one. If not, I'd like to thank a few people for tonight's lecture. First and foremost, of course, our four speakers. I think it was Esme who referred to them as the panel of stunning speakers, and you have all been stunning. I think you have definitely informed us. You've challenged us. So really many thanks indeed. Perhaps you join me with your appreciation. Secondly, I'm very grateful to our planning group for these lectures. There's Lexi O'Shea, there's Alex Brown, there's Bridget Forrest from Blenheim, who's here in person tonight, Paula De Ropa, the events coordinator from the University of Otago in Christchurch, Angela Craig, who's our University of Otago administrator, for great admin support to me. Thank you. Natasha Hoskins, who is here. Danny, clinical lead digital. I think have you still got the same title? And also for Brendan up the back there, thank you for your IT support. So perhaps join me to thank these people. We wouldn't have these lectures if it wasn't for the support from the CARE Foundation, which is up here on the screen. So please speak to Claire, who's here outside, for more information, in particular, if you would like to help. We're very grateful to the CARE Foundation for this. And lastly, thank you all, the Nelson Marlborough public, and also elsewhere in New Zealand, because I do know that someone has dialed in from Taihape, which is quite remarkable. So that's wonderful. Thank you all for joining us tonight, either in person or in Zoom. Now, we do want some feedback from you on this lecture and also future topics. Hard copies will be available for you to fill it in. We'll also be sending you this feedback form tomorrow. So please give us your feedback. We'd be very grateful. So I'm now going to hand over to Alex for a karakia, which will hopefully come up. Thank you.
Ko mutu o mātou mahi mo tēnei wā. Mana I tia mai mātou katoa, mo mātou hoa, mo mātou whānau, mo mātou iwi, ai au ki te arangi, tēnā koutou.